All right. Hi, friends. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller. Today, we have a very special guest, Dr. Michelle Henne. Dr. Henne, welcome to the podcast.
Thank you.
Why don't you tell our listeners a little bit about who you are and what you do?
Sure. So my name is Dr. Michelle Henne. I started a sports medicine practice in Winter Haven, Florida, in Central Florida in Polk County back in 2017. So we celebrated our 5 years of being open at that time. And I've been working with lots of athletes, as well as lots of kids, as well as adults that have had injuries and concussions.
Awesome. Well, that leads us into our topic today, which is concussions. All right. So what is a concussion?
Yeah, great question there. And certainly, in terms of the big scheme of things, a concussion is a traumatic brain injury. There are a spectrum of what traumatic brain injuries can look like, and this is on the mild side of those traumatic brain injuries. It is transient, meaning that it should ideally last for a duration of time before it improves, gets better, symptoms go away. Oftentimes on a chemical, on a microscopic level, when a concussion occurs, there's a exchange of electrolytes that occurs at that cellular level, and then it takes that duration of time for those cellular impacts to get better.
Okay, so how about in the initial, like how it develops, like what is the mechanism of a concussion?
Yes, and I'm huge on mechanisms. And so sometimes I ask my patient, oh, what was the mechanism? And they're like, I'm not sure what you mean. But a mechanism being like, how do they happen? So how a concussion occurs can be one of two ways. It can either be a direct impact to the head. So let's say, for example, two soccer players go up because a ball got crossed. Maybe when we were watching FIFA, we might have seen this. Ball gets crossed, two soccer players jump up and they collide and hit heads. So that direct collision can be one reason, one way that a concussion occurs. And then the other one is going to be more of a secondary whiplash type of event. Sometimes I think we saw that this past weekend in terms of the NFL. Someone goes down and has a whiplash event with their neck and then comes up kind of holding their head is a classic look for that. So there could be one of two ways, either the direct or the indirect.
Is there one that's usually worse than another?
Good question. We don't have any information to say that one is worse than another. It could happen either way. There are other things that could make it worse, but not necessarily how that concussion occurred.
Gotcha. Okay. And what are the typical symptoms of a concussion?
Yes. So concussions are super broad in terms of how they present. And the presentation of a concussion can be pertaining to that when it first happened on the sideline. Let's say you're out with your kids and you're at a soccer game, or you are at whatever that sporting event might have been where it had initially occurred. One thing we know is that some people have immediate symptom presentation. And what that may mean is that in the first 15 minutes after that head injury, that direct or indirect head injury, they've now developed symptoms. Whereas some people do have a delay in their symptom presentation. And so those folks that have a delay, it can increase their likelihood of continuing to participate in spite of that concussion because it hasn't totally presented with symptoms yet, or it can also increase the risk of having another injury, and we'll talk about that soon. Now, the initial question was, what might those symptoms be? And those symptoms fall along a few different areas. Those areas can be physical. The most common thing that we talk about with concussions are headaches, But concussions can also present with neck pain. On the physical side of things, there can be visual symptoms. So physical, visual. Now, visual symptoms may be sensitivity to light. It may mean blurred vision. It may mean double vision. It may mean, some of these things we do also want to consider. Maybe there is another cause, and have a look at that. But so physical, visual. The next one is balance or vestibular, which you may have noticed. There was a football quarterback, Tua, from Miami, who plays for the Dolphins. He had gotten up when he had a concussion and had a lot of difficulty with walking. And so that difficulty with walking was reflective of that balance or vestibular system being impacted. So almost like this, drunk looking gait, having difficulty there. What I do in my office is I have people close their eyes, they have their arms out, and they have to balance, and that balancing can be very difficult when you're not having the visual input where you can see which way is up and down, and so you can start to see that balance or vestibular system has been impacted. The next, and there's a total of 6, so we're getting there. So number 4 is cognitive. So cognitively, we can have difficulties with attention, concentration, memory, and then the sleep. Sleep can be impacted. It's hard to know that when you're at a at a basketball game or football game or whatever it might be. But certainly over the next couple of days, you can start to see is sleeping impacted, and sleep can be impacted in the perspective of being more sleepy than usual, and where we're fatigued all day long, or it could be the opposite of that, where we have insomnia or having difficulty falling asleep. And then finally, number 6 would be emotion. I'll tell you, in covering as many football games as I have, one of the concussions that I had diagnosed that kind of stands out to me was where one of the players had come over to me and said, "Hey, Dr. Henne, I want you to take a look at this kid. I'm worried about him. There's something wrong," and had come over and he's crying. And I said, what's going on? And he can't remember the next play. Then he's crying about it. I asked his teammates, like, is this a kid that generally cries? Because, some kids do and some kids don't. And so his teammates were like, "No, I've never seen this kid cry in my life. Like, this kid does not cry." And so he actually, over the next hour, he ended up developing the headache, the most common symptom, but he had initially presented with just that intense, emotion of the sadness.
Awesome. So basically, when you're there on the sideline, you have a certain evaluation that you need to do. I'm guessing using all the 6 criteria that you just mentioned, right? And then I'm sure in the office, there's slightly maybe a different evaluation. What can you do on the sideline to evaluate?
Good question.
Whether they can go back in and play, basically.
Yes. So you want to walk through all of those 6 areas and make sure that they're not having symptoms within any of those areas. You can also check and do kind of a quick evaluation of their mental status, and they call them Maddox questions, but it has to do with, let's say, for example, it's Friday night, we're at a football game. Most of those players should know who they're playing. They should know about what the score is. They should know, whether or not what half we're in. Are we in the first half, the second half? And then who did we play last week? Who won or lost last week? Did we win or did we lose? These are pretty simple things that, even no matter the age level, they should still be able to have a pretty good understanding for, especially those high school kids. So that would be one way that I assess them on the sideline, along with those symptoms. When we are in the office, things are a little bit more controlled. The energy and emotions is not quite as hyped as it might be, on the sideline. We're trying to determine, is this kid or athlete, is this athlete safe to return to play? Once we're in the office, the thought process here is that kid has persistent symptoms. We want to be able to assess and determine how they're going to, what's going to be the plan of care for getting them better, so that we can get them back on the field. So in my office, what I tend to utilize is either the adult or the child SCAT, which is a concussion assessment test, as well as the VOMS. It's a vestibular, so that was that balance system, and then oculomotor screening. And what we found was that when we combined the SCAT and the VOMS, our diagnostic ability and our sensitivity for being able to diagnose concussions significantly improved. So with those two things together, because let's say, for example, if we didn't include the VOMS, we may miss some of the people who have visual or vestibular symptoms.
That's great. I don't remember, excuse me, learning the VOMS as much. So I'm like taking notes, and that's super helpful for me. So you kind of assess the criteria of whether they can go back and play. I guess on average, how often would you say it's like going to be a long-term thing, like where they aren't going to go back the next day or next week or?
Right. Yeah. So that's oftentimes, especially when we're in season, that's always if it's not the kid or the athlete's question because they're a little bit out of it, it's definitely the parent's question. And that has to do with, the coach is asking, they're trying to figure out, do we need to, bring another player in, start preparing another player for that particular position for this upcoming, next week's game. And so in general, there have been several different studies that have looked at it, and a lot of them have had slightly different statistics, but in general, the one that I have quoted most often was showing that 85% of athletes return to play or at least resolve from their concussion within 8 to 10 days. Okay. So I tend to follow them every 2 weeks, and that's just in case, let's say it's a little bit more towards that 10-day window, but I tend to follow them at 2 weeks to make sure that they have completely resolved with those symptoms and their concussion testing is now normalized. So then we can start our return to play protocol.
How many of your athletes do you think have like a baseline SCAT? Do the programs do that, or what level do they start to do that?
Yeah, so it depends. Realistically, depends on which organization they're involved with. How do they have athletic trainers? So if you look at, county specific, there are certain counties that have athletic trainers associated with every single school. Polk County in Central Florida is not one of those. So some of the schools have athletic trainers. And then it's also a huge undertaking for the athletic training team, the staff who's there. When I'm associated, I work with some of the local universities. And if I'm seeing them for their concussions, then they are often coming in with a baseline. And so ideally they'll have their baseline, and they will have their post-concussion, kind of new assessment. And ideally those are being done also on the same framework. So let's say, for example, so I work with Polk State College. For all of our women soccer players, they all get a baseline VOMS and SCAT. When I work with some of the other universities, they have other tools that they use. Concussion vital signs is out there, impact is out there. These are all somewhat, name specific. I don't have a certain preference. It's just, it would be ideal to have a baseline and then a new re-eval after a head injury.
Okay. I was going to ask kind of next on basically the changes that have been made maybe since I played soccer growing up, right? So we used to be able to head the ball, right? And now they postpone that until I don't know what age, but I'm just curious of what changes over the last, I don't know, since I played soccer, several years of what has been made in the athletic community. So
yeah, good question. And I also grew up playing soccer, so I was definitely right there with you. I'll say some of the biggest changes have had to do with the return to play protocols, because soccer is unique in that it is the only sport where part of the sport is an intentionality of hitting a flying projectile with your head.
Mhm.
So when you have had a head injury, this is a sport where you certainly want to know in advance of participating in your next match that you're not going to become symptomatic from hitting that flying projectile. So what US Soccer did is they created as part of the return to play protocol, which is typically 4-day protocol, they added 3 additional days, and they kind of stuck them kind of right in the middle of that return to play protocol, where you go through a heading progression, a 3-day heading progression. The first day of that heading progression, you're doing headers inside of the 6-yard box, so fairly short distance. On the next day, you're doing them inside the 18-yard box. And then on the third day, you're doing those outside of the 18-yard box, which is a fair amount of forces going in at the head. But certainly we want to know before we're back into full contact play, whether or not do we redevelop symptoms? Is this something that is safe now at this point to participate in that contact activity? That's especially true because soccer, especially women's soccer is such a high risk activity for concussions.
Definitely. With the NFL, do you know their protocols?
Their protocols are going to be very similar to essentially everyone else's, where you're going through and you are increasing heart rate for the first day. You're doing some sport specific drills the next day. And then you are getting into non-contact activities and then full contact activities, and then you're back on the field.
So all those things that you're saying that you're kind of assessing each time, would you say that's the treatment, or what is the treatment for concussion?
Yes. So treatment. So what we're talking about is a return to play protocol, and that most athletes, that's their biggest question is, when am I going to get to play again? Realistically, when they're student athletes, ideally they're returning to learn before they're returning to play, and they're able to get back into all of the academics with, a either improvement or decreasing impairment of cognitive function, if that was one of those 6 areas impacted. So we're returning to learn, we're returning to play. Those are on the tail end once we've improved from a concussion. So what the treatment entails, most of the time, it entails more of a rest and recovery type of approach. However, sometimes, let's say, for example, if we're having persistent headaches or neck pain, we may be assessed to determine if we need to have physical therapy as part of our recovery process. We may need to get a home exercise program. In more extreme cases, we want to consider things like occipital nerve blocks, some of these more advanced procedures. If it's visual and vestibular, those are where I often provide people with either a home exercise program again, or they're working with a physical therapist. And ideally that physical therapist is well versed in the challenges of how people recover from a concussion. So a little bit more vestibular therapy specific to concussions, because a lot of the vestibular therapists are doing a lot of stroke related stuff and things of that nature. So, and that can become also very relevant if you have like dancing athletes who do rotatory movements. So that could be dancers, cheerleaders, gymnasts, athletes of that nature, where you're having to do things through the air, you're rotating. So getting that component of it resolved before you return to play would be important. Cognitively, sometimes academic accommodations have to be made. Sometimes I work with neuropsychologists. Let's say, for example, if a student athlete has an underlying maybe they didn't have a learning disability, but now they are having difficulty with learning and we need to have them assessed. Or maybe they had just, underlying, like under the threshold of ADD or ADHD or a dyslexia or something along those lines. And now with this injury, with this brain injury, now they've come to the point where they're now definitely having a significant symptom burden with it. The neuropsychologist can often be helpful in those scenarios. I typically start with a very simple, academic accommodation. I tell parents I'm not a teacher, and I don't want to teach the teachers how to teach. My goal is to allow for these accommodations and the teachers to determine with their students, because some students, they may have difficulty with math and not English, or difficulties in certain areas that they're going to need more accommodations, and maybe they need less accommodations in some of the things that are a little bit easier to them. So those might be available. If it gets more pronounced, a neuropsychologist helps us, and sometimes we even need to go so far as developing like an IEP or something along those lines that provides a 504 plan that could give us some additional, a little bit more long-term academic accommodations. And then sleep-wise, that can certainly be treated if it needs to be, as well as the emotion could be treated if it needs to be. Ideally, like I said, a lot of these student athletes, a lot of these athletes, they are going to recover without the need for medications, but we certainly want to be screening, monitoring, following, and ensure that should they need something additional, that we're there to screen for that, pick it up, and then provide it to them.
I didn't realize that you might need such a multidisciplinary approach, but that's really nice that you have access to all those people as well. I wanted to ask about the medication part. I can't think of like what you might give for medications unless you're like treating the symptoms really, or.
Yeah, you're more so treating symptoms. So it really depends on which symptoms are going to be most present. Headaches in general, we tend to utilize Tylenol most often for those. But I've had some folks, if you have a history of a migraine disorder, then you're more apt for having a more prolonged concussion recovery course. So sometimes maybe this is someone who previously for their migraines were using certain medications, but now they need a little bit of a controller versus just an episodic treatment. So you might be treating that underlying migraine disorder that has now become exacerbated. And then you can always kind of transition that care later. The sleep-wise, melatonin is a simple one that they could trial. Another sleep one is that I sometimes will use, and most, like I said, most of the time I don't use medications unless they're having prolonged symptoms, right? If they're going to have symptoms for a week and a half, there's no reason for us to start any medications. But if let's say we're now 6 weeks, 8 weeks, out, and we're still having symptoms, we're like, man, okay, let's see if we can, for sleep, for example, amitriptyline. I use a low dose amitriptyline sometimes for those, and it'll also help in with the headaches. And so there's some additional medications that can certainly be utilized, and it's just a matter of what is this particular person going to need.
So I'm going to change topics a little, well, not topics, but what is the risk, and really who is at risk if you send the player or the athlete back in too soon? Like what could happen?
Yes. And that one, I honestly, I use that particular argument for the kid who comes in and it's towards the end of their season, basketball, football, soccer, whatever it might be. But let's say we're getting towards the end of the season and they're like, why can't I just play? So, okay, let's talk through this one, because I understand that you're frustrated. So what are the risks of, let's say you haven't yet fully recovered from a concussion and now you're returning to play? There's two big ones there. One is that you significantly exacerbate the current concussion. I show people often, because the symptom scale that I use is 1 through 6, and there's about 50 symptoms on there. And so they go through these, and 1 through 6, 1 through 6, 1 through 6. Let's say, for example, they're all 1s and 2s, like into the mild. when I have had folks who have either accidentally or unintentionally, or whatever it might be, maybe they had 2 back-to-back significant head injuries, didn't recognize maybe that the first one was a concussion, but then had a second one. Or maybe they got a concussion and then they got into a car accident. Again, out of their control. It just happened that they were in the car that got into a car accident. Those people went from 1s and 2s to 4s, 5s, 6s, right? Now they are significantly impacted. So that risk, you have a 3 to 4 times increased risk of having significantly worsened concussion, repeat concussion. The other one, and even sometimes more relevant, maybe a little bit more kind of grabbing for those student athletes, is the risk of musculoskeletal injury. What we find is that after a concussion, people's balance can be off, the reaction time can be off. And when we have those components, then they're not always measurable, they're not always significantly impaired, but it's impaired enough that they have a 2 times increased risk of having a musculoskeletal injury if they return to play too soon before they've recovered. What does that mean? That means you could take a 2-week concussion injury and turn it into a 9-month ACL injury, surgery, rehab, recovery process. So, and that, you know, if you kind of look at it this way, and most of the time when I give the athlete that option, they're kind of like, oh, yeah, no, I think I'll just sit out for the 2 weeks, and I'll come back, see you, we'll make sure everything's good, and then start a return to play.
That is a smart approach for sure. So what are long-term consequences of concussion or multiple concussions?
Yeah, good question. So long-term wise, when we are talking from a concussion standpoint, certainly the vast majority of people will get better very quickly from a concussion. But I will tell you that, especially in my office, I have quite a few folks out there who have had more prolonged symptoms. And so, we start talking about post-concussion syndrome. Again, there's some disagreement on what the diagnosis is for that, whether it's symptoms more than 4 weeks, more than 6 weeks, more than 8 weeks, more than 3 months. I've seen all of those published in the literature. They're treated similarly. We continue to screen them similarly, but rather than seeing them every 2 weeks, when we start getting out that far, I'll space out the visits a little bit more. We'll definitely start becoming more multidisciplinary in our approach. We would, in most of those scenarios, we at least want to reassess to see if we need some additional imaging, whether that's an MRI of the brain, looking for some type of structural injury or something underlying that may be contributing to the reason why this is persistent. It could also be looking at the vascular structures, the vascular flow through the brain. Sometimes people are increased risk because they actually from birth have had, abnormalities in their vascular flow. And so those are certainly some considerations to have. So we might want to consider some additional imaging when we talk about chronically. Now also I had alluded to that before. So after we've had a concussion, our risk of us having another concussion is higher. Mm-hmm. And I say that because let's say, for example, Joe here before concussion and Joe here after concussion are both riding in the same car. They suffer the same impact. It's the same forces, the loads, everything about it is the same. The likelihood of Joe post concussion is higher for him to have a second concussion than it is for Joe pre-concussion, right? And that's just an example. But that history of a prior concussion does increase our risk for having a future one. So it might be, particularly if we're in a sport or activity that is higher risk for having concussions, it might be a consideration for us to, take a season off, or maybe consider changing which sport we're participating in. If we play in 3 or 4 sports throughout the year, maybe we say, you know what, I'm no longer going to participate in this sport. I'm going to really focus in on my other sports that I was already participating in. So that post-concussion syndrome is certainly there. And then, there, at least in the last several years, there's been a lot of consideration for looking at the more significant downstream potential effects of things like CTE, chronic traumatic encephalopathy. It's a mouthful there. And when we look at CTE, what we know is that we don't necessarily have if I have this many concussions, I am going to develop CTE. At this point, there's actually a higher consideration that the higher number of subconcussive impacts, the more of those subconcussive impacts we have, the higher risk we are of developing CTE. And so it's definitely a question of, is this one concussion definitely going to cause us to have CTE? I certainly have some parents who are worried about that. And we don't know. We don't have quantifiable studies to look and say, because CTE is still technically a autopsy diagnosis, meaning you have to not be alive anymore for us to get some brain tissue to diagnose it. And we can't, you just can't do that kind of study where you whack someone one time in the head intentionally and then take a piece of their brain tissue. There's nobody that's going to sign up for that.
There is a way to donate your brain after you die, to do that, and that they're doing a lot of good research on all of those things. And I know several NFL players obviously have been diagnosed with that, and obviously a lot of veterans as well from the concussions that they obtained in combat. But I'm trying to think of the name of it. There's also the Concussion Legacy Foundation. I have a friend on the advisory board there, and she does a lot of work through that. And I believe her late husband had donated his brain for research as well. So let's say there's an athlete at a game and they don't have an athletic trainer and there's not really a doctor or anything like that. Where can they get help?
Yeah, if the parents are very concerned, the parents can always take them to the ER. In the ER, what they would be determining is whether or not they should get currently a CT scan, or if they don't fit criteria where they need a CT scan, to at least connect them with their pediatrician or their family medicine, primary care doctor, whoever that might be, and or a sports medicine physician. And so by helping to facilitate that, it sometimes gives them just that peace of mind of, especially if we look back to historically we were told, don't let your kid fall asleep. And these poor parents are like sitting here, constantly poking their kids all night long, like, don't fall asleep. I don't want something bad to happen to you. And those periods, those moments can give those parents reassurance right when it happens, right? You can give them all the training in the world leading up to it, but they're not always paying as close of attention until it's directly relevant to them. So that's always a potential is to go to the ER urgent care, something along those lines, something that's open, on the weekends or the nights. That's when all the sports activities are occurring. Definitely an athletic trainer is going to be a super helpful resource if that's available. The primary care doctor is going to often be a very helpful resource. And then your local sports medicine physician. Often, once you get to them, they typically become kind of the quarterback to determine what are those other people that we want to have on the team based on the symptoms, based on the parts that are most impacted by your current concussion.
Gotcha. Is there any other advice you'd like to give our listeners, or anything that you wanted to discuss that we missed?
Oh, well, I wanted to throw in one other thing that's kind of on the radar of things that are coming down the pipe. I've been asked about it a few times, and I continue to follow and check into the data to see where are we at. But that's in regards to biomarkers, right? In regards to, are there any lab tests that'll help us to diagnose concussions? And right now, all of the lab tests that are available are being used in more of a research setting only. And so we don't have yet lab tests, but certainly these are on the horizon. Keep your eyes, keep your ears peeled to listen for those. It certainly would be helpful in that ER setting to help reduce that number of CT scans. It'll be helpful. Some people come in and they're just not sure, is this their normal migraine headaches that have been exacerbated, or is this a new concussion if that was their only symptom? That's often, as a delineator, that's often where these biomarkers will become helpful. but there's a couple that are in a little bit more of like more progressed, more closer to clinical application, clinical utility, that we can be able to utilize in the future.
And you're referring to blood tests, right?
Blood tests, yes.
Okay, just making sure for the people out there. Okay. Anything else you want to bring up, or?
I would say that's the big stuff. I like if we wanted to, what's another really good resource is always the international conference. They have international conferences on concussion in sports. So international wise, right? Not just United States, but across globally. Those specialists all within concussions get together, they in Zurich and in a variety of oftentimes European countries, is where they're located. It was supposed to be completed last in 2020, was going to be our number 6, our 6th, it's every 4 years concussion meeting, but that has always been a great resource where they really in-depthly review what is the research that's on the horizon, where are we at, what can we apply now, what should we not be fooled by in terms of some of the marketing gimmicks and whatnot, and where are we headed so that we can best treat those folks around us who have concussions. So I would say keep that one on your radar as well.
Awesome. Thank you. So if someone wants to work with you directly, where can they find you?
So they can find me at Relevé Sports Medicine. We have our social media handles at Relevé Sports Med, and then also Relevé Sports Medicine on Facebook. I'd say that those are the best ways. And then if you're in Central Florida, Polk County, you can always look us up. Who's the best sports medicine doctor? And we'll be high up there on the list.
Awesome. Well, thank you so much for coming on the podcast, Dr. Henne. It was great having you. Thank everybody for listening to the Get Healthy Tampa Bay podcast. I hope you'll join us for next week's episode. Don't forget to share this episode with your family and friends and review us on iTunes.